Good evening, everybody. Welcome back to the second episode of our article review webinars. You'll see we have the same culprits on the panel. I'm pleased to say we have StJohn, Carl, Manoj and Fadi. And Fadi, I believe we're going to kick off straight away with you this evening.
Okay, thank you very much. Yeah, welcome everyone. So the format is this time to talk about one paper each, which we've chosen, and then we'll open it to questions from the panel and from anybody listening. So I'm going to kick off with my paper. I'm looking at a paper which is from an open access journal, and I'll bring that up in a moment. It's the title of the paper is Angular Changes in Implants Placed in the Anterior Maxilla of Adults. So let me just share my screen and explain why I've chosen this paper. Now, can somebody confirm you can see my screen?
It's quite dark.
Can you see it at all now?
No, not yet.
Oh, yes.
Ah.
Yeah.
Yeah. Can you see the article?
Yeah.
Yeah, great. So this is from Clinical Oral Investigations, and it's an open access paper, so anybody can access it. So this is talking about the changes in angulation of implant position that were placed in anterior maxilla using Kefalometric studies. Now, it's a pilot study. I chose this because I thought it was a really, really clever thing to look at. Although it's a pilot study, it's a nice design, and it's an important point, actually, because there is a fair bit of data on the fact that the way implants work, they ankylose, don't they, like teeth. They ankylose, and because of that, as the facial growth carries on during adolescence or early adulthood, the implant stays where it is, and the rest of the teeth can move down and grow beyond it. So there is a fair bit of data and evidence to show that if we place implants in somebody who's still growing, we can have some aesthetic issues a few years down the line, asymmetry between the implant and the teeth, adjacent teeth. But nobody has actually looked at changes in the angulation of the implant. That's really important because actually there are two potential complications here. One of them is the aesthetic issue, obviously, because there is a step defect from where the implant, when we place the implant initially, face grows down, the teeth grow down, and the implant stays where it is. So aesthetic is an issue, but there can be a functional issue as well. These guys have looked at teeth in the anterior segment, so 3 to 3. And as you know, we can have canine guidance, we can have anterior guidance, and if there's a change in angulation, there could be functional issues. So the guidance can be affected later on down the line. So we know that one of the ways to look at when growth stops, adolescence growth really ends when the epiphyses of the long bones are closed. And that tends to be typically around 18 years old in males and 15 in females. But there is, as I said, evidence that craniofacial growth continues in adulthood. So the aims of this study were really two main aims. One of them was to look at the possible effect of the residual craniofacial growth on implant angles. And they did that by measuring the long-term angular changes in the implants in the anterior maxilla. And they also looked at the long-term changes on the angles in the maxillary incisors so that they can put the two together and compare what's happening with the incisor angle change, what's happening with the implant angle change in the same patients. So the inclusion and exclusion criteria is really, they looked at cases with a single implant in the maxilla, anywhere from 3 to 3. The patients had to be 18 years old or over, so nobody below 18. And they needed to have had a Kefalometric analysis at placements, and then at least 5 years post-placement. So there was at least 5-year period of growth. Exclusion criteria included things like any birth defects, if there were any complications around the implants like periimplantitis, if they had any orthodontic treatment or orthognathic surgery. So any of those cases were excluded. So I'll go down to the diagram, to this figure. Can you see that image? Kate, can you see my cursor moving on the image? I just want to double check.
Yes.
Right. Yeah. So this figure shows what they measured. If you look at image A, they did Kefalometric analysis. They drew a line from the nasion to the sella and from the anterior nasal spine to the posterior nasal spine. Then they drew a kind of a longitudinal axis of the implant. So they took the midline of at the neck of the implant to the middle of the apex of the implant and extrapolated that line to both the ANS, PNS, and NS lines. Okay. On the B image, they did exactly the same thing, but they took the incisal edge of the incisor, adjacent contralateral tooth, and then to the apex of that tooth. They looked at two angles. So the implant's SNL angle, so this angle here, and the implant's NL angle, basically, the angle here. The second one, so the angle around here, the implant NL angle is looking really at alveolar bone growth changes, whereas the implant SNL angle is kind of an indication of the whole maxilla changes and any changes in the whole maxilla. They then looked at how can you make this accurate, and we'll go through some of the limitations of this paper that the authors talk about. The accuracy was kind of improved by having a single person, a single researcher recording this. The researcher, all the measurements were then double checked by two other researchers before they went to analysis. What they also did to ensure his or her accuracy was to, with that, the knowledge of the measurer, they got him to duplicate 21% of the measurements. And his accuracy was 99%. The correlation coefficient was 99%, so pretty accurate. The findings from the study were interesting. So they saw that after a mean follow-up of 8.5 years, 81% of the implants placed in the anterior maxilla showed some rotational changes, ranging from 3 degrees clockwise to 3 degrees counterclockwise, so coming out to 4 degrees clockwise, with the S and L angle, right? So the top, what looks at the full maxillary angle. So 81% had changes in that perspective, and that was the primary outcome measure they had. That was the primary outcome measure. The secondary outcome measure was the NL angle. 50% of implants showed some similar range of rotational changes, but in the NL angle. So the NL angle at the alveolar area were smaller than the SNL angle in terms of the prevalence of changes in angle. So what these findings really suggest from just this result is that you can't put the rotational changes, the angulation changes of the implant, you can't put them down just to the alveolar bone growth. You have to take into consideration that the actually maxillary bone growth has also affected that angulation change. So that's one of the things.
2 minutes, Fadi.
Okay, I've got to have to speed up. The SNL angles were found to be kind of more 50. The changes happened in 58% of females, but 100% of males. So it affected males more than females, and it also affected patients who had the implants placed below the age of 30 more than the ones who placed it after the age of 30. So that's not a surprise. You would expect the growth to slow down as they get older. The limitations were, look, Kefalometric analysis, you get observer dependence, can be very subjective, and you've got the kind of overlaying of structures. One of the points, the sella, is a floating point, so to speak. It's a bit harder it's one of the harder points to identify because there's not one specific point. Relatively small size, but it was a pilot study. and they were relying on a two-dimensional study. So they suggested perhaps doing something along the lines of an MRI in the future. The changes are important and significant, but they're not saying that we shouldn't place implants in everyday growing, because we don't know what the threshold is, the threshold of angle change that will affect function or affect patient satisfaction. So I think it's important. I think it's really important to think about. I had never thought about the angulation change of the implants, but other than that, it doesn't mean we have to change how we do things. We normally go with implant placements at 21 years of age, but it does make a change for our consenting of the patients. You know, that not only the vertical position can change, the angulation can change as well. In some patients, that could be significant. Done.
Thank you, Fadi. Gentlemen, any questions? Anything you want to raise?
Prof. Crean, particularly, to be gentle.
I am as gentle as they come.
When I mean, I was sort of, how many implants were in the study?
Right, so they had, let me just bring that up very quickly. I've forgotten.
Sorry, Fadi.
No, that's all right. I should have remembered that. So they had 57 female and 43 males.
Okay. And were they all the same age again that they were placing all the
Yeah, the mean age range, the mean age was 38.
The mean age was 38. I mean, it's interesting, isn't it? I mean, you know, it's not something I've thought about or ever put in the consent for patients.
No, me neither.
And, you know, there's certainly a few patients on the younger side, especially more now, I think, than 5 or 10 years ago, that are coming in and asking for implants. That instinctively, my preference isn't to place implants, but to kind of, and rightly or wrongly so, kind of push them down whatever alternative is there, not because of the angulation changes, but purely because they've got a finite lifespan with implants. And in my opinion, it might be a good option, but it's the final option in certain circumstances. For younger patients, I would much rather they had a bridge, if that was possible, you know, a conservative bridge or a denture, but not I don't know why. That's me instinctively, I think, for the reasons that's an implant is the final thing, in my opinion.
Yeah. So
in certain circumstances, I'm not talking about every single patient, but I'm saying in certain circumstances. So it's an interesting, but that's also a factor now that we've got to think about as well.
Fadi, did you see the SNL angle was the changes were more pronounced in males than in females? Oh, that's surprising, isn't it? I would have thought that growth is longer, or the duration is longer for females. I would always think
the changes were greater than the NL angle, but it was also greater in males than in females, and the age is expected. Yeah.
Does that not match up with the kind of the growth patterns, though, between men and women, with women kind of growing a little bit more mature quickly than men, and probably staying more mature than men for the rest of their lives?
Yeah, perhaps. I think one of the interesting things is what the SNL, people who have looked at the vertical dimension, they found that very similar results in regards to the vertical growth percentages, the prevalence of growth in the vertical dimension was very similar, 73%. But the other studies, when looked at vertical only, they didn't have the same results with the differences in gender.
Yes, yeah.
So when they only looked at the vertical dimension, other studies, apart from one, haven't found the same, difference in the gender patterns. Whereas in this study, it's a small study. They say themselves a small study.
Yeah.
Quite neat. I thought it was a very good idea to look at angles.
Yeah, I agree.
It's something that, I mean, in what we do at UCLan, what we say that we place implants at 21. and somebody's had to have a tooth out, we do ridge preservation, allow growth to take place, and then so that we don't lose all the bone. But there are some people who place implants in adolescents, particularly for hypodontia.
Yeah.
But yeah, look, it might not change what we do. It doesn't mean we shouldn't place it, but we need to be aware of it.
Do you, when you say 21, do you also sort of factor in, do you ask any questions about that kind of growth pattern?
Yes.
Because you can get very tall 21-year-olds and you can get 21-year-olds that are still kind of growing. So that comes into the assessment. Yeah, me too. Yeah, absolutely. I can see. Yeah.
To be honest, one of the points about this, yes, I probably would advise not to place before 21 and ask some of those questions. I don't think we can justify necessarily taking x-rays to see if the epiphyseal plates have closed, but I would warn them, even 21, even at 30, even later, I think I'm going to start adding this into our consent. Look, even if you're 30s or 40s, your facial dimensions can still change. We're talking something that might not be visible to you, but when it comes to the level of the gums and your implants, it may well be visible. And just add the consent. That doesn't mean, if you wait, how long are you going to wait? There's been evidence that the vertical dimension changes even in the 40s and 50s.
Right, 1 minute, guys.
I think my understanding, you're talking about rotational changes. Is that right in this?
Yeah. Anterior-posterior.
Did the patients notice?
Interestingly enough, they didn't look at that, but they mentioned it because they don't.
That's a shame, isn't it?
It is. It's a shame. And they've said it that what they need to do, they need to have a large enough number to figure out what is the threshold of that angle change. So they said it was between 3 degrees anti-clockwise, 4 degrees clockwise. They don't know what the threshold here is before the patient notices.
Did they tell you what the occlusion was of those that went clockwise and those that went anti-clockwise?
No.
Because, it's a strange phenomenon that teeth tend to move as you get older because we're biting down an incline, as you know, and there's a resultant force. So, and did they measure any changes of the non-implant teeth?
Yes. So they compared in each patient, they looked at the implants and the incisor. And they saw that there was a change in incisor, but the rotational change of the SNL with the implant was greater.
So you could hypothesize that might go down to periodontal ligament and proprioception and
perhaps.
Responses, yeah.
They also excluded patients that are obviously going to have issues that cause proclination of the teeth and so on. For instance, tongue thrust or thumb sucking and stuff like that. Well, thumb sucking at 18. But
I mean, you can look at this and say that if teeth move with age, so will implants.
Well, yeah. I mean that's the issue, isn't it? That the implants can change rotation, but they're not at the same rate as the rest of the teeth. So we know in the vertical dimension they're not the same. This pilot study showed that actually angulation changes are not the same either. So not only you're going to get vertical discrepancy between your implanted teeth, you're going to get rotational discrepancy as well, which can have an effect on your guidance as well as the aesthetics.
Okay.
They're the only ones who've looked at it, as far as I know, as far as the authors aren't aware of anything. I've never heard of that. I hadn't actually even thought about that aspect of an implant.
Right, gentlemen, are we okay to move on?
Yeah.
Fantastic. Right. Was it over to you, Carl?
It is. Yeah. Thank you very much. Cheers, Fadi. Thanks for that. So my paper is from the same journal as last time. So this is the International Journal of Oral and Maxillofacial Implants. What I probably failed to remember is they bring this out bi-monthly. So the articles that I read last time covered pretty much the whole of the journal. So I've selected another one, which I thought might be interesting. It kind of sparked my interest a little bit. And the title of the paper is, Does Chlorhexidine Prevent Complications in Extractive, Periodontal and Implant Surgery? And it's a systematic review and a meta-analysis with a trial sequential analysis. And the paper basically sort of talks about chlorhexidine being widely used. This was performed by some private practitioners and also in Italy with the University of Campana in Naples. And you know, it's quite a nice little paper. Why it kind of sparked my interest was because there was lots of talk, what seems like an age ago now, but at the beginning of the first lockdown with AGPs or AGEs, whatever you want to call them, and how we should be treating patients and whether mouthwashes were of any use. And I did a lot of research around that to sort of look into those side of things. And one of the things that came out of that research is that chlorhexidine mouthwashes were not really going to be very useful in helping. And we can maybe talk about that a little bit more at the end of this. But what they did is they sort of selected very well a number of papers. They ended up with 32 papers that they felt were suitable. And they used a pretty sort of substantial and well-reported PICO and inclusion and exclusion criteria. And their measures that they looked at were sort of implant survival in patients after 1, 2, or 3 years. They looked at tooth survival for the periodontal patients after 1, 2, and 3 years, or this is what they were hoping to look for. And then clinical attachment level loss in periodontal patients in some of the outcome measures. They were also looking at bacteremia and swelling and infections and failures. And they were looking at what they termed sort of safety complications and incidences of alveolar osteosis. So I thought that was quite interesting in that they were looking at this and they were trying to find papers that had done some of them had done split mouth and looked at patients that had the mouth rinse and not had the mouth rinse. They then sort of presented the results in a fairly basic and simple way to understand it. They did lots of analysis on this. They had originally over 2,000 papers, which they narrowed down to those 32, as I mentioned. And when they narrowed that all down, they found that only 27 papers actually focused on the oral surgery procedures. They had 4 left for perio and 1 on implant surgery. And that sort of sparked my interest a little bit because certainly on the periodontal side of things, we've looked at sort of chlorhexidine mouth rinses and we talked about this, but then I realized what they were focusing on was periodontal surgery procedures. And that made me sort of think, well, maybe they've got a lack of papers on that because when we do the periodontal surgery, what we're actually doing is we're kind of disinfecting and debriding the area that we're doing the surgery on anyway. So it may not be reported on much, whether it's used pre-procedurally as an adjunct to patients. So you're probably going to find limited papers on that. And when it comes to the implant side of things, again, they found only 1 paper that sort of fitted into their criteria. And I thought that was quite interesting on the implant side of things. So when they've tried to extrapolate that, we have to kind of understand really they've only got sort of 4 on perio and 1 on implants, which is, I thought maybe we could discuss afterwards. But what they actually found when they looked at the results is that chlorhexidine does seem to have an effect on preventing alveolar osteitis after extractive surgery, they termed it as, which I thought was, you know, fairly interesting. It seems logical that that's gonna happen. I would have liked a bit more in-depth analysis on the papers they used. They didn't really dive into giving any more information. So there's no information on the medical history of the patients that they've talked about. There's no information on sort of smoking. So I would have liked a bit more systemic history on the patients they're talking about. I would have liked to have understood what type of teeth they're extracting, whether these are periodontally compromised teeth, what type of surgery procedures. I would have just liked to I know that these things are difficult, but I would have liked to have seen that in the paper so we could have had a bit more of an analysis about the whole thing. In their discussion, although they seem to have done some nice statistics, they say that there's actually an increased benefit of about 13%, or you get a reduction of about 13% of osteitis when you do the comparisons of patients that had the mouth rinse and didn't have the mouth rinse. And they kind of leave it at that, really, which is a bit of a shame, because I think there's so much more that they could maybe come in and talk about on this. They do talk about the difference in the concentrations. They do talk about potentially being able to use a gel in the site that they're thinking of doing the surgery, so it localizes more. They do talk a little bit about how the chlorhexidine sort of sits in the tissues for a little bit of time. And then they go on to discuss a little bit about chlorhexidine mouth rinses after the procedure. They do mention that they've excluded studies where patients were given antibiotics as a pre-procedural adjunct to the extraction patients and to the implant patients. But I thought it'd be nice to sort of bring it up and discuss it in terms of what we do. Because I thought, although there were very basic sort of conclusions there, and the conclusion is that if you're going to take a tooth out, it might be nice to give your patient a chlorhexidine mouth rinse. But I was wondering what the incidence was of actually osteitis in patients and bacteremia, and the incidence of sort of osteitis that I could see. And St John, you might chip up because you probably know it like that. It's about 2-3% of patients, as I understand it.
What, we're getting osteitis? Probably better saying 5 to 7.
5 to 7%. So if we're getting a reduction in that, I think that's beneficial. So it makes sense to use something as an adjunct if we're seeing some kind of results. But I'm just not sure that the results are all that sound. But it makes sense to kind of reduce the bacteria in the mouth in terms of when we're doing these surgical procedures. I think that when it comes to, and this is my personal opinion, I'm coming off of the paper now, when it comes to things like the implants and the perio side of it, well, we're talking about different situations compared to an extraction. And this is why I would like a bit more information on this, because in my mind, if we're taking a tooth out that has active infection, there's actually active infection in the site. So that's probably going to lead to more complications. Whereas if we're doing an implant procedure, then we're using sort of sterile techniques. And therefore, is the chlorhexidine going to be beneficial? And by the time you've actually taken your scalpel after the patient's had the mouth rinse, how much of that bacteria has sort of repopulated the area that you're working in? And again, with the perio surgery, similar situation with that. I'm not sure how beneficial chlorhexidine is going to be in those cases, and how much bacterial load we reduce. And that kind of follows on to the papers that I read when we were talking about sort of using them as a pre-AGP procedure for patients, or a pre-mouth rinse for patients. In fact, it was almost done in a lot of practices that I worked in where they were using either iodine or hypochlorous acid mouth rinses, because they felt that was more antiviral. And then the papers have kind of since developed that kind of suggest that actually it's a bit of a waste of time. And that's because they feel that the virus is coming from the respiratory organs, the lungs, and the tissues around there. So giving that mouth rinse is making very little difference to the viral load, if you like, when it comes to patients that we're treating with that potentially hazardous, and I'm not going to go into great detail about it because I'll start fuming, things like that, AGP or AGE procedure.
2 minutes, Carl.
Yeah, well, what I'll do is I'll just bring that paper up, hopefully. So let's see whether or not you can see the little guy that I'm talking about. There you go. Is it up on the screen now? Is it?
Yes.
So that's the paper. I thought it might be sort of worth a discussion, really. That's why I brought it up for us guys to have a little chat about and see what your thoughts were.
Brilliant. Thank you, Carl. Guys, over to you.
Carl, there's obviously another thing to all of this, isn't it? We've now been seeing some reports of allergic reactions to chlorhexidine.
Thank you. Yes, I'm glad you mentioned that, because I think that's really important. And I totally agree with you. And this is one of the things that I think is hugely important. You got the risk benefits, and I think along with the increased reports that we're getting of allergies, it's certainly certainly worth bearing that in mind.
I think the only comment I'd make about that is, whilst clearly there's allergies to chlorhexidine possible, quite a lot of the chlorhexidine vehicles are corsadil. And you have to recognize that there are other elements in corsadil people can be allergic to. Whilst it's probably likely chlorhexidine is playing a role, when you ask people whether they're allergic to chlorhexidine, that's quite a good idea. What you've also got to ask is, have you had any reactions to corsadil? For example, there's peppermint oil in corsadil, and there's not an insignificant number of people who demonstrate allergies to that. So that's quite a complex subject.
It is, and one of the things that they mentioned in this study is they don't mention any brand names, but they do talk about sort of concentration levels of 0.2% and 0.12%, and they talk about rinses and gels.
Yeah.
But they don't talk about any complication side of things.
Yeah. I mean, going back to your paper about the reduction in dry socket, I'll be honest, there's nothing new in that, in the sense that although I was just trying to see, they're American, these authors, are they?
Italian, I thought. They could.
Right. EDS, yeah, okay.
Yeah.
I don't know who will be in the audience listening to this, but if they're of my age, there is still a very strong research group out of Sheffield Dental School, the Clifford. It was headed by a guy called Peter Robinson, and he wrote a lovely paper where he demonstrated that if you extracted a bunch of posterior teeth, single posterior teeth, and in some groups you use corsadil to clean the tooth, and by which I mean not just rinse, because of course rinse will get to superficial layers. What they used to do was put the corsadil on cotton wool and clean the tooth with corsadil, so that you had physically and chemically removed at the same time, and then took the tooth out, that it significantly reduced dry sockets. So from a result perspective, that's nothing new in that. What I would say, and for those of individuals who have a look at in vitro work, and the connection between in vitro and in vivo is difficult, and I'm going to present an in vitro study, which it's a big leap. But if you were to have a Petri dish of osteoblasts and fibroblasts growing healthily, and you added 2% corsadil to them, they would all die. And corsadil is extremely toxic to connective tissue cells, those in the vicinity anyway. The depth can vary. And that has translated in the clinical world, and you'll speak to most plastic surgeons, maxillofacial surgeons, people, for example, who are repairing incisions or lacerations, wounds. They will rinse with corsadil because it has fantastic antibacterial, but you have to make sure it is not the last fluid that you leave in the wound. You then have to wash it away with saline, because otherwise, when you close the wound full of corsadil, if you translate the in vitro to the in vivo, there's a risk you're going to affect the quality and the time it takes to heal. So don't underestimate the effect of corsadil on exposed connective tissue. The last comment I will make is, and you didn't talk about it, which is about bacteremias. You guys know that I'm very interested in bacteremias from oral bacteria and where those bacteria may end up. And I've got, I've been involved, and I'm still involved in quite a big group looking at whether oral bacteria may play a role in neurodegenerative diseases like Alzheimer's. And there's quite a lot of evidence showing there's an association. It's got to the point now, every night, I will use mouthwash before I clean my teeth, because I'll use the mouthwash to try and kill off as many bacteria as I can, because I know when I clean my teeth, I'm going to get a bacteremia. And so I'll use a mouthwash before I clean my teeth to reduce the bacteremia, because if I'm susceptible to Alzheimer's and it's inflammatory in nature, I don't want any oral bacteria in my blood, if that makes any sense. So I'll shut up now.
No, that's great. I mean, they do mention a little bit about the bacteremia, and they do say that it is reduced with the chlorhexidine wash. But that was only a couple of papers that measured it, so they kind of skipped over it, the lack of papers that they managed to include into their paper.
I think you will introduce something like Porphyromonas gingivalis into your blood when you clean your teeth. Maybe not every night if you're fastidious, but it will happen. And my advice: I'm
not going to clean my teeth then.
Don't do it. Just use the mouthwash first and then clean them.
1 minute, gentlemen.
What's your view on using peroxyl? Because I know some practices I've worked with, they've had so many issues with potential allergic reactions or suspected allergic reactions that they've just stopped using chlorhexidine. Instead, they use peroxyl. I wonder if there is, I don't know of any studies where they compare chlorhexidine to peroxyl in terms of reducing bacteremia or bacterial load. But the point you make, St. John, is also very important with treatment of peri-implantitis. I stopped using chlorhexidine on implant surfaces over 10 years ago because of its cytotoxicity, and also because it adheres to the surface, doesn't it? No matter how much saline you throw at it, it will still adhere to a certain extent.
It's charged, isn't it? So any opposite charge is going to latch on. Yeah,
maybe it would be worth doing a study on comparing chlorhexidine and peroxyl in terms of antibacterial effects in the mouth.
I think there. Sorry, Kate. I think there is a study about a comparison within the mouth, but not a very detailed one, because a lot of these studies that they've done recently have been quite rushed. Kind of all these kind of COVID studies that they were looking at, and they were looking at them in relation to the exposure for an AGE kind of point of view, if that's what you want to term it. And so they're interesting, but I think we need some more long-term studies on them. But I totally agree. I stopped using sort of Cortidil as it was on those implants. St. John, do you feel there's any difference on whether it's an extraction socket or whether you're actually placing it directly onto bone in terms of allergic reactions? If it was Cortidil, if it was
you've got more chance if there's a bleeding socket.
Yeah.
You know the photographs I've shown you of the multiple foraminae in an extraction socket. So there's definitely more opportunity there. It doesn't mean there's no risk on bone. There are still immune cells in your in bone surfaces, not particularly on periosteum, and but not as dense as it is in blood coming out in a socket.
Thank you.
So again, I would keep away from Chlorhexidine and extraction sockets. Saline is as good as it comes.
Great.
Kate, I'm only doing this so I don't have to do my papers. If I can drag this on a bit longer.
You carry on, St. John. You carry on.
There is no time
to say that if colleagues who are listening to this, there's another thing to take from that presentation, and that is the methodology that they've used in that paper, Carl. I think if people, dentistry and dentist professionals, we've got to do more of these mini systematics, even meta-analysis, and the more comfortable we get them and we take away the mystery of them, the more evidence we'll be able to introduce into our clinical practice. And from what you described there, that sounded like a well-designed methodology.
Very, very much so. Really clear, and hence why they had such more number of papers, because they were so strict with the way that they did it. So,
those of us who maybe students out there have done master's degrees, and you narrow it down and you've still got 32 papers, your heart's going to sink, because it takes a lot of work to go through 32 papers with all the various criteria.
Fantastic. Well, thank you very much, Carl. Thank you, St. John. Manoj, straight over to you.
Right. So I've been looking at sinus lifts, really. So we obviously have two standard sinus lifts. You've got the crestal and lateral approach, and you go in there. If you've got lack of residual bone, you lift your sinus membrane up. You chuck some bone material in, whether it's bovine, synthetic, whatever you fancy, and then you either place an implant then, or you place it later. Now, I've been looking at a paper, a recent one, which is from Dr. Shalu Bansal et al. They looked at sinus lift procedures in dental implants. There was a systematic review and a meta-analysis. And what they were looking at was new bone formation that took place and implant osseointegration, either with or without graft material. So bone gain in sinus without graft material was the primary outcome they were looking at, and the secondary outcome was implant survival. So we know, especially with crestals, that we quite often, personally, I do, and I know Fadi does at the university, if you're doing a crestal approach, we're looking at a certain amount of residual bone height available. Generally, we look for at least 4 to 5 millimeters bone available. We lift the membrane, and we don't pop any bone material in for various reasons. The common one being it's generally a blind procedure with a crestal approach, and if you do have some bone materials migrating up the antrum, blocking up your sinuses, then that's not a lot of fun. We do know that lifting up sinus membrane leads to a clot. The clot obviously presents benefits. It's got growth factors, it's got bone, it's got BMPs, bone morphogenic proteins that are activated after tissue injury. And furthermore, the Schneiderian membrane has osteoprogenitor cells that help in bone formation. Now, so basically, you've got a clot connecting to titanium surface, generating thrombin, and which contributes to osteoblast activation and gives you bone growth. So these people looked at, they did a systematic review and a meta-analysis on maxillary sinus lift and implant placement. They did electronic search on PubMed, Medline, Cochrane, Web of Science, and they looked at papers from 2005 to 2020. They looked at both prospective and retrospective cohort studies, controlled clinical trials, and RCTs. They excluded case reports, animal studies, and case series, and of course those in the metabolic disorders. And they had 2 review authors who conducted the screening. They also used the Cochrane collaboration tool to assess the risk of bias. So overall, it was a well-designed study, I thought. They got 25 papers and they brought it down to 18 studies. The meta-analysis was conducted only for the experimental studies, which compared sinus flow elevation with and without grafting. And in total, they had 749 sinuses that were lifted or elevated, and 1,034 implants were installed. They found that 26 implants failed with a mean survival rate of 97% without grafts. And with grafts, 13 out of 213 implants failed with a survival rate of 94%. They also found an average gain in bone height of 4.7 millimeters over an average of 39.4 months. And this was observed in sinus elevated without grafting materials. And again, with implants, there was a cumulative average survival rate of 97%. Yeah, some things, yes, smokers, they found, had a slightly higher failure rate. And strangely, there was no impact on the perforation of the membrane on implant success. And I mean, it is interesting. When we, as I say, when we do it, I would generally not place any bone material inside a crestal approach, but the height of bone gain did take me by a bit of surprise. And yeah, there are a lot of other studies out there which show good success rate with crestal and lateral approaches with or without bone graft. But yes, the fact that you could potentially just regenerate bone by lifting the membrane and leaving it as it is worth looking at. With a lot of cases we do, a lot of mentoring we do. We have students who want to put bone material in all the time. and it's a lot better to be safe than sorry. But yeah, I thought I'll leave it at that and open it up, because I think there's a lot to talk about in this. So yeah, over to you guys.
Manoj.
Thanks, Manoj. Out of interest, I get excited when there's sinuses involved. So basically, the residual bone height, did they actually look at the direction of the residual bone height loss? So in other words, was it alveolar bone loss or was it pneumatization? Did they actually even look at that as a
no, but they looked at pneumatization for sure, but there was no specific mention of alveolar bone loss. Yeah. What they did do is in the selection criteria, the average bone height was 3.54 plus minus 1.2%. So you had crestal approaches without a bone graft for RB, residual bone height of 3.5 millimeters.
Because the outcome measures, if I remember correctly, they looked at implant failures, right, as well as sinus infections. Is that right?
No, they looked at the bone height as the primary outcome, right, and implant failures or success as the secondary outcome. So they were primarily looking at bone gain after the procedure, and implant failures were the secondary option. And despite that, as I say, success rates were high. And this is a good number of implants and a good list of papers they've picked up. 18 papers for systematic review.
The reason I mentioned the residual bone height is because, I don't know, in my mind, the clinical crown length has got to have a role to play in terms of complications, restorative complications particular, but restorative complications can result as a secondary thing to implant complications.
Yeah,
and I haven't seen any paper that talk about maxillary sinus grafts that ever mentioned the direction of bone loss, which is interesting. I thought, in my mind, that's quite important, because in terms of long-term successes and so on, especially if they take implant failure into consideration, a long clinical crown might have an impact on cleaning, on maintenance, and so on. The other thing is the sizes of the implants. So I don't know if they mentioned that, because if you have residual bone height of 5 millimeters, you put an 8 millimeter implant, as we teach, as you know, then you're only lifting the sinus by 3 millimeters. So even if there is a tear, you could say, okay, well, I'm not putting material in there. The blood is going to cover that 3 millimeter of implant. And but if you're putting a 12, 14 millimeter implant, that implant is going to sit in air inside the sinus. That makes a difference. That's the other thing. I don't know if they looked at that implant length.
So that's where that's what got my interest, because here they found bone height of up to 4.7 millimeters over a 39-month period. So if you're getting that sort of bone height, you're obviously putting implants that are longer than 4.7 millimeters into this. And that's what caught my eye really about the paper. They're getting a tremendous amount of bone height in these papers. And the different osteotome techniques. You could have, the old techniques, the newer ones, denser, versa, what have you. But that's a lot of bone height to get.
Irrespective of technique, irrespective of direction of bone loss and implant length, they still had pretty good success rates.
And that's without grafting. And obviously now you have a lot of patients out there. The moment you mention lateral sinus approach, they seem to disappear. They think it's an open heart surgery. And I have found, I don't know what you guys have found, over the years, I do fewer and fewer lateral approaches. Quite often I'm doing crestal approaches. I used to do lateral approaches left, right, and center. It was just a routine thing to do. It's become few and far between.
I refuse to talk about it because you so-and-sos have stopped doing them. I don't earn any money anymore.
You just do it ourselves nowadays.
You can all rot in hell as far as I'm concerned.
Carl, you're muted.
2 minutes, gentlemen.
What's that, Carl?
Carl, you're muted, yeah? Carl's talking to himself.
He is.
I was agreeing with Sinjan. I was saying it's not as much fun, doing the crestal approach as the lateral approach. It's far less fun. But Fadi, you mentioned there about the length of the implants, and I'm really glad that I didn't talk about it, but there was a paper again in the same journal that actually talks about the success rate comparing the length of implants in sinus grafts, and it shows that the longer implants, you get more failures.
That's interesting.
Which was sort of what you were saying there, Fadi, really, that you're popping a lot of that implant into nice, fresh sinus space, potentially, or more graft, potentially. It's one maybe we could look at another time, but I'm really glad I didn't bring it up tonight, because we would have been cross-referencing. But I think that's very, very interesting. Certainly more bone height than I would have expected.
A lot more. Yeah.
And did they talk about the techniques? That when they're talking about lifting the sinus, are they using sort of the saline to lift the sinus up, or are they using osteotomes?
No, they looked at a variety of papers from 2005 to 2020. But no, they don't specifically mention different techniques. And that's what I said. There are different kinds of techniques. But irrespective, even if it's the old technique, the Summers method of just pushing the membrane up, that's still a tremendous amount of bone height to get.
It is, isn't it?
I mean, nowadays we've got burrs and stuff that push bone up and do all sorts of weird and wonderful things.
Was that average bone height, Manoj?
Yes.
So there would have been some more and some less.
Exactly.
Now, you mustn't forget, this sounds a bit pedantic, but you're only getting bone, as you highlighted, because it bleeds. Yeah. We all have different bleeding times. Some people will bleed for 2 minutes. Some people will bleed up for 10 minutes. Therefore, it's no surprise that in some individuals, you're going to get a lot more blood. And therefore, you're likely to get more bone, which there's a natural biological explanation. And of course, the other thing to think about, which I think would be a fascinating study, is do people on aspirin or antiplatelets get more blood when you do those sinus lifts? And therefore, do they get more bone? And of course, I bet you they didn't mention whether they're on antiplatelets or aspirin or anything like that. No.
I can see Fadi jotting that down.
Oh, I know. He hasn't had an original thought for 30 years. I'm going to charge you for that one.
I wasn't born 30 years ago.
Talking about bleeding time.
Come back.
My favourite answer to what's the bleeding time is when someone says 5 seconds. That's important.
Right, gentlemen, are we ready to move on to StJohn?
Thank you, Manoj.
I'm going to reap. What am I going to get? What I reap now, aren't I? So, in the 6 minutes we have left, can I keep dragging it out for 6 minutes? I would like to finish on an in vitro study. So it's a heads up to the audience about things coming in the future. Perhaps I've been to the Journal of Dental Research. I haven't gone too far back to 2019. Remember, it's not an implant journal, but it's got an impact factor pushing 5, which in the world of dentistry is pretty good. I'm looking at a paper that comes under the heading of Research Reports, Biomaterials and Bioengineering. And it's from a group headed by a gentleman called Zhou, spelled Z-H-O-U, for those of you. And the name of the paper is Anti-Diapogenesis, which means anti-fat, and osseointegration of strontium-infused, or doped as they call it, implant surfaces. And these guys are from Hangzhou, the affiliated stomatology hospital in Zhejiang University. Really good university, guys. I can't tell you. They do a lot of really good work. I sometimes worry about the ethics of the human studies they do, but they just hurl money at their research. It's a factory. Anyway, I took an interest in this paper because, as Fadi has just hinted, I'm quite old, quite rudely in public. And I am, although I seem to have most of my teeth at the moment, there's a risk, of course, at some point they may disappear. And my mother was a good example of an elderly individual who was still having implants in her late 70s and early 80s. And there are challenges, aren't there, when we are replacing missing teeth, not necessarily just in our younger generation, middle-aged. We've heard tonight of a group whose average age was 38 in a systematic review, but in an elderly population. And the problem with the elderly population who will come to you looking to restore their occlusion, to restore their appearances, restore their function, that we start banging into diseases, of course, which have effects on our bone. And the obvious disease is osteoporosis. So how do you feel about putting implants in individuals who have, or the risk is, may develop osteoporosis in the future? And if we refer back to the same story I keep going on about, which is trying to give all your patients at the consent stage the material facts, which is a code for all the material facts. You've got to be able to tell them what's likely to happen as they get older. And osteoporosis can happen, of course, in individuals who go forward. And picking out who's at risk is sometimes easy if there's a family history, or they've had surgical removal of ovaries, or they're on hormone suppression treatment, or lots of steroids, lots of risk factors. But what if they're a good candidate for implant replacement? Well, this particular paper was looking at infusing or adding onto the surface of dental implants strontium. Now, strontium, in summary, is an anabolic agent, and it's used in the treatment of osteoporosis. It's not frontline, clearly, but it is used in many areas of the world as a treatment for osteoporosis. And the reason being, if you ever look at a slide of osteoporosis, what you see is that the bone is disappearing, not just the calcium. So you're not just left with high connective tissue, you lose calcium and connective tissue. And when you lose that bone, the bone then gets replaced with fat, adipogenesis. And so what strontium does is it inhibits fat formation and it favors osteogenesis, particularly if it's acting upon bone marrow stem cells. So the mesenchymal stem cells, particularly, that are the derivative of the future osteoblast mature cell. So they looked at an in vitro study. I noticed the time. I'll summarize that they looked at strontium-infused titanium, which was, the titanium was sandblasted, large grit sandblast, and they also used SLA, acid-etched SLA, before they added on the strontium. And the bottom line was, by using various measurements, they looked at the effect of strontium on surrounding tissues, on systemic features of bone. And strontium had a number of anti-inflammatory effects. It was an antioxidant, preventing the free radical presentation. It inhibited certain genes from forming that would, particularly with inflammatory cells, that would lead to free radicals being performed. It reduced oxidative stress, which, as you know, the ability that reduced the exchange of electrons, basically, therefore stabilizing tissues as opposed to destabilizing them. It increased the production of what's known as glutathione peroxidase, which is a protective molecule. You remember back in your old days, it eats electrons flying around the place in the shape of hydrogen atoms. So it takes in the extra electrons, again, calming the environment down. They showed in vitro that there was a reduction in lipid droplet formation compared to the controls where there was no strontium being used. And finally, they demonstrated there was a significant enhanced osteointegration in rat models. They used animal models where they put the implants and controls into the tibia of the animals, and they showed a significant enhanced osseointegration with an inhibition on the marrow fat tissue formation. So it's one for the future, maybe. Strontium definitely has had its role. That's clearly this in vitro and animal studies have got to translate into human studies. But all these results definitely give an impression that strontium infusion onto various surfaces of implants may have a potential application for the provision of dental implants in an aged population in whom there is a risk or an ongoing activity in the osteoporotic environment. And with that very short message, I will be quiet.
Thank you, StJohn. Gentlemen, over to you.
And if anybody asks me horrible questions, I will remember.
We've got an eject button, StJohn.
Thank you.
I'm in trouble already. So, out of interest, StJohn, were they using the strontium? Because strontium itself is one of the alkali earth metals, isn't it? So, were they using it as an alloy with the titanium during the production? Do you know, or was it as an additive onto the surface?
The methodology. Great question. Just give me a few seconds. I think they added it to the surface rather than an alloy.
Okay, so that I think
they use the word doped, but your question is a really good question.
Because if it's an alloy, then they would have to look into the effect it would have on the strength, on the obviously tensile strength and what have you. The other thing, if it's an additive, we've had some issues with additive things. If you remember the plasma spray stuff before and hydroxyapatite that would come off the original stuff. So as you're placing the implants, they can come off, and that's another thing to look at. One other question I had, if you don't mind, was how did they measure osseointegration? They said that it improved osseointegration. So did they have a control, presumably with just titanium? And then
they compared it. So they looked at gross volumes of bone, but they also looked at the release of various enzymes and markers of bone formation in and around the implant arena.
Those was histological slices and so on.
Very much, and with a bit of biochemistry added in. But there was a lot of histomorphometric analysis.
Yeah.
So would you think that this kind of research, I know we need more on it, but in terms of where we would go with this, would this then maybe lead us towards selecting a particular type of implant for a particular age of patient?
Don't you think that's where it's all going anyway?
Yeah,
Isn't medicine going down the personalized medicine? Yeah. And why shouldn't dentistry go in the same direction? We're going to need to know genetic risks, obviously, add on environmental factors, and you'll have a formula for what works best for that individual.
Yeah.
Pharmacy, medicine, dentistry, why shouldn't it? It'll keep Fadi in the lab anyway, messing around with
yeah.
years.
They've looked at all sorts with it's interesting, the anti-inflammatory side of it, because people look at zinc, the anti-inflammatory, and copper for antibacterial. They're doping all sorts of bone substitute. And I know people have been doing the research on strontium with biomaterials, but I didn't know about it on implant surface, which is interesting.
That's because you don't read enough. Call yourself an academic.
Well, I'm going to be injecting this stuff into my stomach because I could do with getting rid of a few little bit of animal tissues. So.
I think there may be one or two side effects you need to watch out for.
But that'll be all right.
Anyway, it's one for the future to think about. But I think the personalized dentistry is something, you're young enough, guys, but the generation coming up behind you and behind them will be. Even in dentistry, it'll be personalized to their genetic risk factors and background. Absolutely.
Yeah, and I think I think that's where it is going, isn't it? It's kind of, we look at the patient as a whole in an individual, and then we've got this selection of what we know works well in those particular patients, and we just take whatever fits to it and tailor it to the patient. And I think that the more we look at, the better that's going to get, and hopefully the longer term success rates we're going to get.
Quite agree.
Kate, are we taking questions from people live or not?
I don't think we are with this one.
They can do, I think. I just don't think anybody has dared to ask a question, but I think there's an opportunity.
I wonder who they are scared of.
Seriously?
I didn't mean you, Prof. I don't know.
Manoj, it's you.
I think we have got a question.
I was going to say that.
So the question that we've got is, if the clot breakdown is not due to microorganisms, how would you attribute the reduction in alveolar osteitis post-chlorhexidine? So I think, Sinjin, I'll let you answer that one. Do you want me to repeat the question again?
Yeah.
If the clot breakdown is not due to microorganisms, how would you attribute the reduction in alveolar osteitis post-chlorhexidine?
I'm afraid my only answer to that is I think bacteria do have a role in the clot breakdown.
I agree. Yeah,
that's my instinctive reaction.
Yeah,
the author of that question poses a really good point. But because I don't know the answer, they can go away and stop.
It's a great question.
It is a very good question.
Great question.
I mean, there are many theories, aren't there? Remember, we're talking about bacteria here. There are viruses which have been associated. As you know, dry socket in temperate climates is more common in that sort of winter-spring period. Yeah. You know, just around the cold season, the viral cold season. That's been put forward as a possibility. But, you know, you've only got to look up the properties of streptococci. It has many connective tissue enzymes. It has it can break down clot. It has many enzymes that break down clot. So we know that's how it can spread. And that's why the theory of if you land them in the socket post-extraction, they are likely to, there's a risk that it'll break down the clot. I think we go back to our previous comment, which is, in all seriousness, I think you've got to have a predisposition to this as well. I think there's a genetic predisposition to the fact that bacteria will break your clot down, and that's going to depend upon what proteins and sequences you've got in your various connective tissue and thrombus and all the rest of it. It's a fascinating subject.
Could the question be related to the fact that we say don't give antibiotics to prevent dry sockets? So why is it that we don't give antibiotics? Is that why the question is asked, perhaps? Could be. So if the bacteria are involved in clot breakdown, then why is it antibiotics don't help?
Yeah, but do antibodies get onto the surface of a tooth? If you swallow an antibiotic, it gets into your blood. Is it going to get into the surface of a tooth? Because that's the thing. I guess you're saying the antibiotics will kill it once from the blood once they get into the socket, I suppose. Yeah. They'll be in the clots, presumably. Well, actually, yeah. We often give it post-operatively, don't we? Rather, we used to give it post. I think the antibacterial effect of an antibiotic in blood is minuscule compared to a big, strong dose of chlorhexidine on a surface. Mm-hmm. Right. I mean, you know, we've got to be careful. We're calling chlorhexidine antibacterial. It's true, but chlorhexidine will kill everything. Yeah. It is, what did you call it? Cytocidal. You know, it is extremely toxic, and that's why it kills stuff. It's very impressive stuff.
Okay, then, gentlemen, is everybody happy?
Yeah, I'm very. Yeah. I've got a spaghetti bolognese waiting for me.
Well, I'd like to say a very big thank you to StJohn, to Carl, Manoj, Fadi. Gentlemen, thank you very much for your time this evening. We will be running these article review webinars fourth Thursday of every month, so please tune in. We're going to have some guest panelists as well, and we will keep you in suspense. More eye candy for the panel, more eye candy. I was very careful with what I said there, gentlemen. So if everybody's happy,
so we just kept everybody tempted.
So if everybody's happy, I shall bid you all a good night.
Good night.
Brilliant.
Thank you.
Bye. Thank
Bye.
you very much.
Bye.
Thanks a lot. Cheers, everybody. Good night.
Good night.